Hello friends, today we are going to discuss about proxy consultation and proxy prescription. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about various definition of this proxy consultation and prescription, what is the prevalence, what are the legal implications, and what are the recommendations to deal with this menace. Proxy consultation. It has been defined by various people. The well accepted definition is consultation by caregiver, that is the family members, not accompanied by the patient, for the purpose of advice, treatment, or second opinion with or without the patient consent. Here, the important ingredient is the patient is not brought for the consultation. The purposes may be various. Invariably, many a time, in various countries, the authorization of the letter from the patient is taken so that they can take second opinion or with regard to diagnosis and treatment is considered. The proxy consultation revolves around absence of patient with or without the consent of the patient. Similarly, what is proxy prescription? Here, prescribing medication to the caregivers, that is the family members, without the patient's physical presence during the consultation. Again, here, consent of the patient may or may not be there. If it is there, either there is a prior authorization letter or consent taken by the service provider so that he can give the prescription to the family members. Again, the proxy prescription revolves around absence of patient and giving prescription to the family members. There is another important term, covert medication. Here, the caregiver or the family member will conceal the medication in food or drinks without the knowledge of the patient so that the patient takes medication. Again, the covert medication is very clear. It is without the knowledge or the consent of the patient. In UK study, covert medication administration appears to be common practice in nursing home. The study said approximately 17% of these nursing homes mix the medication either in the food or in the drinks. Invariably, dementia patients, intellectual disability, patient with schizophrenia, there, when they do not have capacity, the caregiver or the service provider give medication without the knowledge of the patient. Invariably, many countries do have their own legislation with regard to lack of capacity. In UK, Mental Capacity Act of 2005 clearly says that best interest of the patient should be kept in mind when covert medication is given either by the family member or the service provider in the nursing home. Many a time, without the implication of covert medication, in certain countries like Australia, there is something called as medication refill. When the supply of the medication gets low and caregivers cannot bring the patient for prescription, they refill the medication from the pharmacy with or without the doctor's prescription or consultation, and that is medication refill. Various countries have the maximum duration of 3 to 6 months as a medication refill. There are various reasons this medication refill has been brought in. The main reasons are the patient is working, is unable to come, the family member will come for medication refill, or else the patient feels that he is stigmatized, hence he does not want to come. The family member will come and take the medication. And invariably, the service provider also feels that the patient is doing well. There is no need of consultation. It's just a medication refill. Hence, it can be provided for a period of 3 to 6 months with or without the consultation of the doctor. Now let's understand why there is proxy consultation, proxy prescription, covert medication. Invariably, if you look at the psychiatric illness, they are long standing, require medication for longer duration. Whenever the medication is started, if he says, I will not take medication, there is complete non adherence. That means overt non adherence. I will not take medication. Invariably, you can see this in psychiatric hospitals where patient with schizophrenia, bipolar affective disorder, schizoaffective disorder, obsessive compulsive disorder, dementia patients may refuse to take medication. Many a time, if they accept to take medication, but in the OPD, they may stop the medication, or else even in the inpatient, they take the medicine, but they do not swallow it. Sometimes they agree on outpatient, they decrease the medicine, or they may increase the medicine, or they may stop for 1 or 2 days for various reasons. This discontinuation of a medication is the biggest problem, especially in psychiatry. In major mental disorder, 50 to 60% of the population refuse to take medication. It may be intentional and many a time unintentional because there is a supply of medicines may not be available, like during COVID, or else the cost of the medication may be very high. Sometimes they may tell the clinician or they may not disclose that they have stopped medicine to the doctor. That means it is done by themselves without any consultation. Many a time they may stop the medicines or interrupt the medicine for various reasons, as I mentioned. Many a time they forget to refill the medication. Sometimes some of the patients, if they have any difficulty, they may increase the dosage on their own. Again, this can be intentional and unintentional. If you look at the literature in psychiatry, 50 to 60% of the patient stop medicine on their own or they decrease the medicine on their own. There are various factors have been studied across the globe. The first and the factor can be considered as patient factors. The patient may not be aware about the benefit of medicines, side effects. Those are the issues. Many a time the patient stop medicine. Sometimes health related belief. If I take medicine, I am weak, my personality is weak, and hence that health related belief will come in the way of taking medication. Sometimes patient wants to get married or want to become pregnant, and if they have to take this medicine in front of others, what will happen to me? The stigma and discrimination. Similarly, with regard to illness, psychotic illness where the insight that I have an illness, I need to take medication. If such insight is not there, then invariably they stop medicine. If the patient have delusion of persecution, they may stop medicine, thinking that medicines are poison. Many a time the patients who have bipolar affective disorder, they say they would like to have hypomania or mania, which is very pleasant, hence they stop medicine. In some cases, the patients may forget to take medication, and classically you can see in dementia. And many patients talk about side effects like weight gain, hair loss, and various other side effects. And in developing countries, it is the cost of the medication which makes them to stop the medicine. Many times, some healthcare professionals like pharmacists, nurses, MBBS doctors, surgeon say, why are you taking psychiatric medication? Don't take those medication. They are addictive in nature. They will call you dependence. And they'll say you will become psychotic if you take those medication. Since they are not aware of psychotropic medication, they themselves cause stigma and stop the medicines. Invariably, the family members who are supportive, the adherence is very good. If the family members are very critical, hostile, they do not want to bring the medicine, or they stigmatize the patient that you are taking medicine, you are weak, don't talk. Such kind of name calling, or else stigmatizing, or else isolating them can cause poor compliance. And finally, the ecosystem, that is, access to medication, availability of the medication, cost of the medication, how the society sees these people who are taking medication, stigma and discrimination overall causes this poor compliance. Our team did an exploratory study with regard to proxy consultation in severe mentally ill patients. Here, we looked into the what was the prevalence of proxy consultation, especially with severe mental disorder in outpatient. If you look at the study, we approached 1,520 patients, and these patients need to come to OPD with a diagnosis of severe mental disorder along with the family member, and they need to be in the age criteria of 18 to 60. And when we approached 485 patients with the caregiver, 111 refused to give consent. Hence, we were able to recruit 374 patients. When we looked into the proxy consultation, we found that 160 had at least one proxy consultation in the past 1 year, and 214 did not had proxy consultation. As I said that the adherence, when we looked at the best adherence was defined as if the patient was 75% of the time is taking medication. We found that 70% were had a best adherence. With regard to moderate adherence means 50 to 70% of the time they should be on medication. 23% of the patient were on moderate adherence. The worst was 7.5%. Although there are limited studies in India with regard to adherence, the prevalence of proxy consultation, we came to know, was 41% of them had proxy consultation and proxy prescription. With regard to covert medication, 32% of the family members said in the past 1 year they have given medication without the knowledge of the patient. Similarly, another study with regard to schizophrenia, they clearly said 50% of the patient had been given covert medication by the family members. If you look at the caregiver's opinion on proxy consultation, invariably they said 11% said they should never be done. That means the family members said we should not give medicine without the patient's knowledge. Invariably, 40% of them said it should be left to the family members because they are the caregiver. Let them decide how they are going to give the medication. Another 40% of them said we need to discuss with the doctor and decide whether we need to give proxy consultation or medication. Further, patients and family members said 7% of them that it has to be discussed with the patient before in hand. If you look at the number of times in the past 1 year, the number of proxy consultation were huge. Invariably, 4 times was 32% of them had proxy consultation. Does the proxy person stay with the patient? Yes. That means the caregiver are staying with the patient and they are concerned about his relapse, and they are 82%. Do proxy consultation also get prescription? Of course. They are not just come for consultation. They also want to take the prescription so that the patient can be given medication. If you look at the reasons for proxy consultation, the patient is receiving medications covertly. It is very minute, that is 1%. Patient is unwilling to come for consultation. For various reasons, he may be working or he may have stigma with regard to coming to psychiatric hospital. It is 27%. Majority of them found that mitigating the cost. Imagine the patient and the family member have to come all the way to the hospital. They have to spend for the travel. If they have to stay 1 day, the accommodation, the food. Hence, they would like to come alone, invariably, the family member, and they take prescription and consultation. That is 45%. Many a time, patient is doing well and going to work, hence 12%. Locomotor difficulties, where only 7%. Other reasons, like the patient is elderly, doctor has said you can come alone, no need for the patient. The patient has neurological condition. At home, there is emergency crisis, cultural and societal barrier. The patient is a lady who is married. and she is staying with the husband. Hence, she cannot leave the house and come. Proxy prescription and covert medication. Now, let's look into the legal issues around this proxy consultation, prescription, and adherence. This medication compliance, it may be because of symptom, the patient may not have capacity, or he has capacity. It may be asymptomatic, that means he does not have any symptoms, but still, he may have capacity or he may not have capacity. How can it be possible? A patient does not have symptoms, but he doesn't have capacity. Especially in a patient with intellectual disability and he does not have symptoms. That means he's asymptomatic, but he does not comprehend that he needs to take medication. In such a scenario, the whole Mental Health Care Act revolves around the capacity of the patient. Hence, looking at these scenarios, proxy consultation, proxy prescription, or the combination of both, coerced medication, covert medication is common in any part of the globe. That means it is not restricted only to developing countries. It is seen in developed world, in nursing homes, rehabilitation center, even in the community when the family members are looking after the patient. What is the impact? Imagine if we do not give medication, especially the patient with severe mental disorder, such as schizophrenia, bipolar, substance abuse, schizoaffective disorder, OCD. Invariably, if you look at the outcome of these studies, they say poor adherence to medication or lack of contact with the service provider clearly indicates the poor course and outcome of the patient. That means compliance of medication is very essential in psychiatry, especially with severe mental disorder. The simple reason is you can say the patient has a right to refuse treatment. Of course, it is a human right. If the patient do not harm any family member or the people in the society, his rights prevail. If the patient does not take medication and he becomes violent and he intervenes or he causes the violation of rights of the family members or other in the community, that means his rights needs to be curtailed. The best interest of the patient is to give medication by the family member or the caregiver or maybe a service provider. That means, my dear friends, in psychiatry, especially with severe mental disorder, who are known to have severe relapse, violence, conflict with law, assaulting, violence, in such a scenario, the medications have to be given forcibly, many a time covertly, and it is not only seen in developed countries but also in developing countries. Non adherence to treatment can lead to, as I mentioned, severe disturbance, loss of job, increased hospitalization, cost, and also many a time conflict with law and death by suicide. This not only affects the patient but also the family members and at the community at large. Further, research clearly demonstrates there is a correlation between increased caregiver burden, the need to be with him, taking to the hospital, staying in the hospital, violation of the rights of the patient because we need to curtail their rights so that they do not become violent towards other members. That means to uphold their liberty, they can stay in the community. We may have to give medications. Now, if you look at the cause of poor compliance, as I mentioned earlier, especially in severe mental disorder, poor insight, many a time they do not want to take medication because it causes insomnia or maybe they are having sedation, they cannot go to work, loss of wage. Women with mental illness need to come with the family member or she is married, she wants to become pregnant, cost of travel, accommodation, food, stigma and discrimination, side effect of medications. Recently, we have published an article with regard to legal aspects of proxy practice in clinical psychiatry in India. In this, we have considered about covert or coerced with regard to capacity to consent. If you look at the Mental Health Care Act of 2017 of India, Section 4 talks about capacity to consent for admission and treatment. Invariably, the law clearly says in Section 4, every person, including person with mental illness, shall be deemed to have capacity to make decision regarding his mental health care or treatment if such person is able to understand the information, able to appreciate reasonable foreseeable consequences of taking medication or decision or lack of decision, and is able to communicate the decision. With regard to this, Mental Health Care Act of 2017, Section 81 had mandated the central government to come up with the assessment pro forma, and Central Mental Authority has ratified the pro forma on 16th August 2019. In this, there are 5 important elements. The demographic details, along with the obvious lack of capacity if the patient is severely ill, violent, and we cannot engage him in any kind of conversation. In such a scenario, obvious lack of capacity is consent. And the consent will be taken from the nominated representative or the family members. The other one is next is understanding the information, whether he is able to understand what we are saying, whether he is able to appreciate the risk, whether he is able to communicate, and finally the decision based upon the patient's symptoms, behavior, mental status examination, information collected by the family members, by the patient, and others. On that basis, whether the patient has capacity is there or not will be decided. Now, moving to refill of medication. Invariably, as I mentioned, especially in severe mental disorder, in India, 43% of them have proxy consultation for just for refilling medication. Many a time it is authorized by the patient, or many a time it is unauthorized. The patient has not told the family members to go and take the medication. Many a time it can be given by telepsychiatric consultation, where the doctor will contact the patient and discuss about whether the prescription and the consultation will be done with the family members or not. Many a time, the prescription can be also sent to the pharmacy for dispensing the medication. Now, looking at all this, we need to have a recommendation, especially with regard to India, where a Mental Health Care Act of 2017 is silent about proxy consultation, proxy prescription, covert medication. The Mental Health Care Act of 2017 is very idealistic. You need to talk to the patient. We need to take the consent of the patient. Without the consent, you cannot give either the proxy consultation, prescription, or medication. It is idealistic. Is it practical? No. Because you go to any of the psychiatric hospitals, or maybe even the government hospitals, invariably, the patient's family member come alone for refilling the medication. What has to be done? That's the reason we need to have a white paper and recommendation. In this article, we had discussed about this. Here, the proxy consultation. Many time, the patient's family member come to the OPD. They open a OPD slips. Once you start seeing the family members, you realize the patient is not there. The family member want to know whether their ward or their family member is ill, what should be done, how to give medication, or for the purpose of certificate, or whether we should give medication. In such a scenario, you cannot refuse consultation. You need to empower the family members. What is the prevailing law in that country or in India? Hence, you need to give information to the family members, document that the patient has not come, mention what are the information was given. Please do not make any diagnosis without examining the patient. Please don't give any medication. Record that the consultation was without the patient, and clearly mention that in the next consultation, patient has to be brought. If required, you can go one step ahead and do teleconsultation to see whether we can do first consult or not. With regard to proxy prescription, this can be allowed whenever the patient is doing well, and you can give up to 6 months. That is refilling the medication, I would rather consider. Many times you can also do telepsychiatry. This proxy prescription to be given only when the diagnosis is established, when you know the diagnosis of the patient, when you have a good documentation of the patient illness, course of illness, and you know the family members very well. With regard to covert medication, be careful about this because Mental Health Care Act of 2017 revolves around the liberty of the patient. Hence, before you give covert medication either by yourself in the hospital or by the family members, you need to empower the family members with regard to the knowledge of Mental Health Care Act of 2017. Hence, you need to assess the patient capacity. If the patient does not have capacity, either in the nursing home, the nursing staff can give the medication, or else family members can give the medication at home. That means if the patient does not have capacity, the NR will decide how the medication will be given. Invariably, if the patient refuses medicine, parenteral medications can be considered here. And invariably, at this point of time, 30 to 40% come to the hospital for refilling medication by the family members. Hence, in this scenario, we need to allow this. Otherwise, the number of patients who will stop medicine just because they are unable to come to the hospital and you do not give medication to the family members is a grave health rights violation. Hence, we need to allow this refilling of medication. Before you do that, please do take authorization from the patient. It can be written and the patient has signed it. If to the maximum period of 6 months, you can continue to do refilling medication. If required, please do telepsychiatric consultation. And also make sure every 6 months you do blood test and physical examination. But however, we need to balance between the patient's rights versus family members' collective rights with regard to patient illness. That means it is based upon the case to case basis. We need to take this decision whether we need to give proxy consultation, proxy prescription, covert medication, or medication refill. There is no one fit size for everyone is not possible based upon the patient. The patient may be ill at this point of time. We may have to consider covert medication. Once the patient becomes all right, we can shift over educating him, empowering him, and giving medication. That means across the population, within the same population or the same patient, these medication practices can differ. Hence, there should be a collaborative approach between the healthcare provider, patient, and the caregivers. So, my dear friends, you need to understand whenever there is a new patient and if there is a proxy consultation, please empower the family members with regard to the law. Don't make any diagnosis. Don't give any medication. Give what are the possible solution. If possible, do telepsychiatric consultation and document that the patient is not there. Also, clearly say that the patient has to be brought in the next consultation. If it is a old patient and you know the diagnosis, you have a good, very, very good documentation and medical records are there. If there is an authorization letter by the patient, or you can contact over the telephone or televideo consultation, and you can give the proxy prescription. And invariably, if the patient has poor compliance and he has lack of capacity, you can consider covert medication or long-acting injectables. However, please do use telepsychiatric consultation before you take any decision. Further, to improve adherence globally, we need to have a patient-centered approach, such as interviewing the patient, providing information, engaging the patient, focusing on what is the best possible interest of the patient, what is his long-term goals, evoking his emotions with regard to his illness, planning, avoiding relapse, and that kind of patient-centered motivation interviewing can help the adherence. There are studies which have said that, but it requires time. Invariably, to improve the adherence, The number of sessions is somewhere around 8 to 18 sessions, each session lasting for 45 minutes to 90 minutes. If you have that kind of luxury, please do motivational interview and sessions so that the patient takes medication. Invariably, further adherence therapy also can be planned. Again, it starts with engaging the patient, looking at what are the resistance, why is the resistance, providing information to the patient and the family member, minimizing the side effects, generating the discrepancies with the patient and his functionality and belief. And again, here, this kind of adherence therapy also requires time. Involving family members is very essential. If we have a lot of resources with regard to providing therapy, please do consider doing this kind of therapy. But again, after COVID, the cost of each therapy session has skyrocketed. If the patient and the family member is able to afford these therapies, please do consider. Then only we need to consider covert medication or parenteral medication. However, family centered improving therapy, improving the information, discussing about their concern, empowering the family members to give medication also plays a crucial role. Studies have found that if the family members are very supportive, the adherence improves and also the course and outcome. At the same time, we also have to make systemic change. That is, access to treatment at the primary care level should be available. The patient or the family members should not travel long distance to get psychiatric evaluation and to take the medication. In India, we have to make sure the medicines are available at the health and wellness center. That is hardly maybe 1 kilometer or 2 kilometers from the house. That means we need to make sure that the treatment at the doorstep has to be made available. The medicines need to be couriered to the house. And also make sure the healthcare workers go to the house, check whether he is compliant on medication, what is the help required by the family members. We may have to send reminder with regard to SMS, make call, develop an applications, especially in educated patients, so that the patient do not have relapse. But especially in psychiatry, where there is a poor insight, long-term medication, invariably huge burden, and family members, caregiver burden is huge. In such a scenario, we have to make all efforts to take the care to the doorsteps. That is the only way we can decrease the relapse and also improve adherence. So, one of the way to improve the care at doorstep is by telepsychiatry. Invariably, if it is a first consult, make sure you provide information. And if you do not know the identity, ask them to come for in-person consultation. Use follow-up consultation judiciously. And if you know the diagnosis, and if there is authorization letter, please do telepsychiatry consultation, provide prescription, do follow-up, enable the family members. So, one of the way out, especially in India, is for all our inpatients, we need to have advanced directives, authorization to be given to the family members to do proxy consultation, proxy prescription, make sure they do not take advantage and violate the patient's rights. Hence, the AD, that is advanced directives, nominated representative, play a crucial role. We need to empower the family members with regard to medication, knowledge about side effects, and also choice of hospital where they can go nearest hospital and make sure the medication reaches to them either by courier or the patient family member come and take the medication. Hence, we need to allow proxy consultation, proxy prescription, refilling medication, covert medication based upon the patient capacity. Hence, at this point of time, we need to come up with an authorization letter for refilling medication. Advance directive should also have giving permission for the family members to do proxy consultation. And if this is not possible, we need to come up with community treatment order, which is there in US, UK, Australia. Hence, we need to consider even in India. Further, we need to invest in health so that the healthcare workers can go to do home visit and provide care at doorsteps. Of course, Telemanas has been launched in India, and this can play an important role, and there can be a paradigm shift with regard to mental health care at doorsteps can happen shortly. So, thank you very much for your valuable time. Stay safe.